Good
Morning, this is Dr. Rutledge from the beach in Tijuana. And I got a nice letter today from a foreign patient far away. And so I'm going to answer some of her questions. There's a lot here, so this will take a while. My apologies. But there's a lot of good questions, and I'll try and summarize some of these. But I'm going to switch over to the screen that has their questions on it. And as we go through it, I'll kind of highlight and talk about some of that. So here we go. Okay, so here's my letter. Hello, doctor. And she's from another country. And she says, I'm living in Belgium. I don't speak English, but she had some questions about the MGB. So we'll go through some of them. Is bile reflux still symptomatic, and is damage visible on gastroscopy after the MGB? So bile reflux is a big question. And when I first presented the operation, everybody said, all your patients will have bile reflux. The MGB will be bad. And the reason they said that is because there was another operation done many years ago by a Dr. Mason. He was one of the inventors of the mini gastric, of bariatric surgery in the whole world. He was one of the first people to do operations for obesity, and he received a lot of criticism and a lot of accolades because he did it. But one of the first things he did was something called a gastric bypass, but it used a loop like mine, but he put the loop next to the esophagus. And soon those patients had crippling bile reflux, and the operations all were reversed. And the general surgeons, starting in the 60s, began to say that a bile reflux was a crippling problem from anyone who would try to do a gastric bypass or weight loss surgery using a loop, which of course we now know is wrong. But when I first presented this operation in 2000, dozens and dozens and dozens of surgeons got up to criticize me and make various claims. They said everyone will get bile reflux, everyone will get gastric cancer, everyone will not lose weight. And there were a lot of other things, all of which turns out they were wrong and I was right. And many of them, particularly in America, still can't get over the fact that they were wrong. And so in America, maybe the last country on earth other than Antarctica, still not offering the MGB broadly. And so here's the question. Bile reflux can occur, but normally bile reflux is back into your stomach every day with every few hours. And the problem has been shown in studies back in the 1940s and 50s is that bile in the stomach is not a problem if it goes in and washes back out. That's what the scintigraphy studies show. Now, there is some conflicting data in which there are surgeons doing the MGB who have trouble with bile reflux. They've published papers on this. They've operated on people because of bile reflux. And we're going to get to a topic of why we see this paradoxical data in my patients. For example, I'm going to talk about my patients in bile reflux and many other good surgeons doing the MGB in the technique I recommend and treating and recommending post-operative management the way I recommend. And we've had other surgeons publish, and they're good, honorable surgeons. They've said they've had terrible complications and problems from the bile reflux after the MGB. So we have kind of this paradox in that we have thousands and thousands of patients, and in my case, followed for up to 20 years, doing fine. And then we have other intermittent reports from surgeons, often not trained by me, or trained by me, and then they modified the operation to their own taste, and they have had problems with bile reflux. And so we might wonder why that is. And I would say it's because I do it right. So the operation we know done like the technique of Mason can lead to bile reflux. On the other hand, the techniques that I use in the operation in the post-operative management seems to result in long-term low incidence of bile reflux. And we'll come back to this topic a little bit later. But what we're saying here is that I believe, and we have published in hundreds of articles now in tens of thousands of patients for up to 20 years of follow-up, that bioreflux is rarely a problem after MGB. And if it is a problem, it can be traced back to two problems. The bioreflux issues either occur because of technical errors by the surgeons at the time of surgery or due to postoperative management issues. Now, you could say, well, Dr. Rutledge is the inventor of the MGB and he's biased, which is true. You know, it's like if I ask you about your children, more likely you're going to say your child is a good person. And I'll say, well, didn't he steal a car? You say, well, yes, but he's really a good kid. So I'm biased in my presentation and I recognize that bias. So I would recommend that there's something new that you can do, something that is not available even 10 or 20 years ago. And that is you can talk to 1,000 or 2,000 or even up to 5,000 of my patients online today. So for example, you could turn off the video now, and instead of listening to me, you could go and talk to thousands of MGB patients, hundreds of whom are more than 10, 15, or even 20 years after their surgery, and ask if they're having troubles or problems with the MGB, with bioreflux. And what I think you'll find is there is very rare problems of bioreflux unless patients violate some principles which they learn soon after the operation. For example, if you eat a big dinner, you're likely to get bioreflux, because the example I use when you go to the grocery store, if you have a 2-quart or 2-liter container and you try to put 3 quarts in it, it'll bubble back over the top. And that's kind of bioreflux. So some surgeons and some patients can't quite understand this, and they create an operation that causes bioreflux, or the patients are inadequately educated and they don't realize that they can't eat a big dinner. If they eat a smaller dinner or eat more slowly, often that is the cause of bioreflux. Now, because of this confusion, we can then get problems where the surgeons will see a patient with bioreflux, not understand this little paragraph I just presented to you, and they'll operate. And we've seen people convert people to Roux-en-Y, and then they've come back to me saying, I still have reflux. So that's a sad and unfortunate situation. But in short, this is a complicated topic. But what we can say to you is bioreflux done in an MGB, done by an excellent surgeon, by a well-educated patient, is a rare complication, even up to 20 years post-op. Conversely, there's other kinds of reflux, most particularly acid reflux, and that's very common in the sleeve gastrectomy, even in the best hands. So my bias is, if you have a concern about reflux, the MGB may be the best choice, but it's important to remember the surgeon's technique and the patient factors. Okay. Now, the next thing we often hear is that the mini gastric bypass can cause long-term stomach and esophageal cancer. And she said, quote, it's banned in France. Well, that brings up the example I talked about before. The French study appears to have really bad outcomes. And it seems to me it was done by surgeons who were doing either their own technique or something unusual. And I happen to know a little bit of details about the surgeons, that they were not trained by an MGB surgeon who is skilled. They did not speak to me about it. They just read my old article and then called it a 1 anastomosis gastric bypass. And they had major complications, and the whole country of France was stopped using the MGB for a period of time. And then they changed some guidelines. And I won't go any more criticism, but I think the French study is a good example, is you can get major complications if you do an operation incorrectly. And my bias is the French study was a very well done study of an MGB done badly. And so the risk of long-term stomach cancer seems to be much lower in MGB than it is the sleeve gastrectomy or the Roux-en-Y. We know that long-term studies of the operation that we do for the mini gastric bypass, which is called a Billroth 2, shows no increased risk of gastric cancer over the long term. And the one studies that do show slight elevations are done in patients who had the operation for gastric ulcer or duodenal ulcer. And we know that gastric ulcer is associated with a cancer-causing bacteria called H. pylori. So we'll go into this more detail. But the other thing I would say is our research shows that that the long-term success and avoidance of serious illnesses after MGB is much greater than the risks. Obviously, everyone faces risks of all kinds of things, but the MGB seems to decrease illness-associated diseases, and we think overall it's the best operation for patients. Our patients under the age of 30 good candidates for the operation? And so again, we would point out there are dangers long-term for people under the age of 30 of obesity, other bariatric surgery in particular, like the sleeve, the lap band, the biliopancreatic diversion. And so in my opinion, and again, you can talk to patients who've had the operation for up to 20 years, that nothing is perfect forever, but the MGB, in my opinion, is best. And there's more I could talk about that, but we'll go on because I only have limited amount of time. Is pregnancy not contraindicated? So basically my study, I looked at patients who had pregnancy before and after the MGB. And in short, the complications of mini gastric bypass pregnancy was lower after the mini gastric bypass than those who had pregnancies before. So my bias is that you're much more likely to have a safe and healthy child if you have a pregnancy after MGB. Now, in every pregnancy, there are precautions that must be taken, and I won't go into all those at the present time, but overall, the health benefits of the MGB appear to make for a safer pregnancy than having it without the MGB. The next question here that she sent is, should she take a gastric protector, or we would call a PPI, for the rest of her life? Okay, one thing is, the long-term use of omeprazole and other PPIs seem to be associated with the increased risks, including gastric cancer. The other thing is it's usually given to protect against gastric ulcers. And here we have a lot of complex topics that I won't spend too much time on, but the number one infectious disease that causes gastric cancer is Helicobacter pylori, and that's associated with an increased intake of meat, eggs, and dairy, leading to H. pylori infection and gastric cancer. And what we think is that by modifying your diet as forced by the MGB, you're going to have a lower incidence of gastric cancer. The other things we know is ulcers, gastritis, and esophagitis are high in non-MGB patients around the world. So esophagitis and gastritis are common, and we know that meat has been shown and other dietary issues to be associated with that. And we also know that in the sleeve and Roux-en-Y, esophagitis is common and a major problem, leading to a high incidence of revisions after the sleeve. The other thing is marginal ulcers seem to be one of the main problems leading to the gastritis after MGB. And again, if you look at my results and our patients on Facebook, who can talk to, again, up to 4,000 or 5,000 people, marginal ulcers are very uncommon. And it's related in part to dietary management, postoperative management, and to the surgeon, that is the surgical technique. Another question she asked is about a referral. She asked about a specific doctor. And basically, I'd like to say, I spent the last 10 years traveling the world teaching MGB, and I think I've been successful. On the other hand, I don't have any control over the other surgeons, many of whom are now adopting the MGB, but they're adopting it in ways that are similar to what I have done, but oftentimes not exactly. So what I would say is I welcome their modifications. I'm suspicious that their modifications might be harmful because we know at least some surgeons who have modified the MGB are reporting bad results. MGB is now the fastest growing bariatric surgery in the world, and many good friends are using the MGB, but they've adopted their own versions. Okay, so again, think of the French study. Okay, they claimed their operation was an OAGB and referred to my paper, but they specifically had no training with me or other MGB surgeons doing it in the technique that I created. So we see non-MGB surgeons and bad outcomes, okay? I'm now working with Dr. Ilan, and we offer the MGB and original technique, and we are happy to certify other surgeons in offering the original technique. But in short, we believe bad MGBs by non-MGB surgeons can lead to a twisted pouch, a narrow pouch, a short bypass, limb length, low blood connections, and other problems that lead to bad outcomes. In short, I'm happy to talk about this in more detail, but bad MGBs lead to bad outcomes. In case of problems, is it advisable to convert the omega into a Y or into normal anatomy? Okay. Most important is to have a competent, skilled MGB first and later. I would say that MGB is easy to convert. That's one of its big advantages, but in my experience, it's rarely needed. And if you have a surgeon recommending conversion, my bias is you might want to talk to me first. It's a somewhat more complicated topic, but I have never done a Roux-en-Y for any of my 6,000 plus MGB patients. I've never recommended a Roux-en-Y, and my bias is that it's not a bad thing, and other surgeons can disagree with me. But anyways, I could go into more detail on that. So that's a brief review of answering that nice lady's question. I wish her all the best, and we'll go ahead and stop the video there. Thank you all very much. Goodbye.